Welcome everybody to this session. As you heard, I work with JLF in the US. And there in the 5 cities where JLF is, in Seattle, in North Carolina, the 2 new cities, as well as in Houston, New York, and Boulder, Colorado, we tell everybody who comes, please go and experience the magic of the mothership in January. And so I took my own advice, and this is my first time here, but I'm now going to say the opposite, which is please make plans if you can to be in the US in September for this amazing version of what happens here, split across these 5 cities and areas in September. It's a magical way, in a different way than here, but I've just been so grateful to have the opportunity to be with all of you. We have a fantastic panel talking about a very important topic and the issue of vaccines. And we know many of you will have questions and comments, and we will try to get to them. But please try to formulate the questions that you have and follow what we're going to be talking about here. As my panelists and I were preparing for this, we talked about how vaccines, as you heard in the introduction, have been among the most important changes in the history, technological changes in the history of the world. But we are at an inflection point now. And where we go from now depends largely on the impact of work of 3 countries, India, the United States, and China. And we have experts on all 3 who are here with us. Before I introduce my panelists, I do want to say that I'm super excited because my father is here with me. He's sitting in the front. Retired Ambassador T.P. Sreenivasan is here after his 5th book fair in the last month. India is full of book fairs, but this is the original. And he wrote his 11th book for his 80th birthday. So those of you who think you've written a lot of books, he's already hit 11. So let's start with just telling us, Robert, what your thoughts on how you look at the world of vaccines.
Great. Well, thank you so much for this opportunity to be at this amazing festival. It's really an honor to get to speak with my panelists and to speak with all of you. So let's provide a little bit of context on why global vaccination has mattered so much to our world today. Global vaccines really transformed a world where health had become dependent on income. That was not always true. In 1800, health was less dependent on income. In fact, it was the other way around. It was the wealthy, more crowded cities that were less healthy than others. In 1800, the life expectancy at birth difference between the US and India was just 5 years. What happened over the next century was that large investments in water, sanitation, hygiene, nutrition, the infrastructure, the heavy infrastructure of public health started to draw a significant difference in health performance. How much? 2/3 of the US's life expectancy gains or health gains since 1880 occurred before there were vaccines, before there was widespread availability of antibiotics. It happened through this heavy investment in infrastructure. So you go from a time period where there was only a 5-year life expectancy difference between the US and India in 1800 to 1950 when there was a 26-year life expectancy difference between India and the US. And it was largely due to these heavy investments in water and sanitation and hygiene. What shifts after this point is the slow expansion of access to global vaccines, largely. So if you look at 1950, you go from a time period where the likelihood or the percentage of children under 5 that died in India was 27%, just 3% in the US. It has now dropped to under 3% in India, 0.6% in the US. And you've seen this convergence in health, this convergence in access to vaccines. First through the hard efforts of UNICEF, later through the Global Vaccine Alliance, spreading access. But we are, as Sree mentioned, we are at this inflection point. 2022 hit a point where we saw the largest decline in global vaccination in 25 years. That we really see it in the decline in pediatric vaccines. That is attributable really to three different areas when you think about vaccination. There's the barriers of supply, how much we make and where it's available. There are the barriers of demand, which can be tied to people's hesitancy to take vaccines. And then there are the programs we use to increase administration, the barriers of administration to vaccination. We're at a point now where we need to see progress really on all three to regain the momentum that we have had, this transformational use of global vaccines. We need to see more increase of vaccine manufacturing worldwide. We saw incredible disparities between the availability of vaccines for COVID-19. In the first full year after they became available, just 10% of the world's countries represented 90% of the global vaccination for COVID-19. We need to increase that supply. We need to see sustained investment in administration. And there's, I think, a lot of question about what the donor investment is going to be in programs like Gavi that have really effectively not just supported the manufacturing of vaccines, but also their distribution worldwide. And then last, on this barriers of demand, we have to confront, after the COVID-19 pandemic, this loss of trust somewhat in healthcare and in vaccination that people have had. And this is an area where I think both India and the US can learn from one another, and there are lots of shared challenges.
One of the things I did, Thomas, was call you Robert. And I did that because I have a Robert on my mind, and that's Robert F. Kennedy Jr., who, as health secretary, if he is confirmed, brings a whole different dimension to his attitude. As many people here know, and as he testified, that he said that he's not anti-vaccine, is what he said. His own children are vaccinated, is what he said in front of Congress this week. But 4 years ago, he said if he had a time machine, he would go back, and the one thing he would change is vaccinating his children. This is a man whose father and uncle were assassinated. He wouldn't go back to fix those tragedies. He would fix the tragedy of the vaccination of his own children. What is the impact of someone like that leading America's health at this moment?
So we are at a moment where you have seen, particularly in the United States, a shift in people's willingness to get vaccinated that is somewhat political, tied to political lines. A lot of confusion about the role that vaccines played in COVID-19 and where they made a difference and whether or not they helped as much as some people say. So I think there is a need for a conversation around vaccines to try to increase people's willingness to get vaccinated. That is tied to transparency. So the positive side about the conversation we're having in Washington is I think it is important for people to understand that all medical products have a balance of benefits and risks. That taking a medicine will have, and particularly in the case of many of these vaccines, vanishingly small, but health risk associated with it. Being very transparent that there is a balance of health or benefits and risks, I think, are an important way forward for how to do this. So I think there is a version of the conversation we're having now in these confirmation hearings that gets at this transparency. What we have to do is have it be evidence-based, to have it reflect the actual science, to have it reflect the evidence we see there, to be very clear about what the infrastructure that exists, for instance, on vaccine adverse event reporting, what it's there for, and what those numbers represent. We haven't quite gotten that from the political conversation now, but it's going to be crucial moving forward.
And I think for medical authorities, health folks to say what they don't know as much as what they know is going to be important. So thank you, Thomas. Vanshica, you bring a perspective from the world of multilateral banks, and give us your thoughts.
Firstly, very good afternoon to everyone. It's such a pleasure to be here. The first time I came to Jaipur Literature Festival, I was a young, school student, and I've spent a lot of my college years coming here. So it's really an honor to be here and to be sharing my thoughts. Thank you for the context that's been set, and I think I'm going to try and throw light on the kind of initiatives and work that multilateral institutions have been doing in the vaccine ecosystem development phase. If you look at it historically, when a lot of the MDBs came out, if you look at the World Bank and the other Bretton Woods institutions in the 1950s and so on, health and education were critical factors. ADB came in 1966, so it's been a focus. But over the last few decades, I would say 1990, 2000 onwards, there's been a huge shift towards hard infrastructure. And for many banks, the social infrastructure conversation somewhere took a little bit of a backseat. With the COVID pandemic, there was a much needed kind of shock that our system got. And we realized that there needs to be more investment. And of course, there was a rapid response that was happening, but also looking forward to how we can work towards ensuring we're not hit by another such pandemic. So before COVID, on average, the health portfolio, say at ADB, was about 6%. That grew to about 15% during that time of COVID, and now it's become an average of around 10%, which is still a good jump from previous times. And I think now all the banks are very have made health a major priority, which it kind of which had dipped in between. When we look at COVID in particular, because a lot of work was done by MDBs, both in terms of vaccine security and global health resilience, real time, but also building health systems, strengthening and capacity going forward. I'd like to share a few examples. Of course, we know of COVAX, which was a product of Gavi, World Bank, CEPI, so on, which is the COVID vaccine global access facility. From ADB side, we have a $9 billion $9 billion APVAX facility, which is the Asia Pacific vaccine access facility. Which had several sub-initiatives, but two major components were the rapid response component and the project investment component. And I just want to throw some light to show what are the structures through which and the frameworks through which and the resource envelopes through which these institutions have catered to the vaccine shortage and challenge at that point. So on the RRP front, for instance, it provided very timely support for vaccines in terms of procurement, transportation, and so on, real time. And on the project investment component, there has been a lot of focus on successful distribution, delivery, and administrative of vaccines, along with investments in capacity building, system strengthening, and surveillance. And within this, we also had a separate vaccine import facility of about 500 million that was set up to make sure that the DMCs, which are the developing member countries, could access safe and timely vaccines real time. Within this, I'm also happy to perhaps deep dive into some project examples. And I think those years, the bank realized both from the, from its priority side, but also from the country ownership side, that there was more appetite to focus now more on creating a more enabling environment for vaccine development. So for instance, in Bangladesh, we have a huge project that's coming up, and happy to share more details on that. So that's that particular project, for instance, has taken a long time to design and is like a 7-year project that's been rolled out and is currently work in progress. So I think the banks have played a huge role, and there are a lot of projects also based on co-financing, where ADB, World Bank, AIIB have all come together with other development partners. But we must realize that it's a very complex space, because creating an enabling environment means the intellectual property rights aspect of it, skilling of workforce, in terms of supply chain, and everything, the regulatory aspect, market creation, so and also all extrinsic factors and the political economy as well of the country. So with that, I think I'll pause, but happy to share perhaps a country example as well.
Let's do a country example very quickly. I think maybe the Bangladesh case, if it's would be helpful for people to understand what you were able to do.
Absolutely. So in Bangladesh, we have it's a 350 million USD project, 368 million to be very precise, which is a seminal project between ADB and the government of Bangladesh, which got board approval in 2023, and it's currently work in progress from 2023 to 2030. It's a 7-year project with 2 phases, but I will just pause there and give more context on why it's important. As we saw during COVID, within the LMIC bucket of countries like
low and middle income countries.
Yeah, low and middle income countries. Countries like, of course, India, which have a large pharmaceutical market base, etc., who could quickly domestically produce and supply vaccines, not only for the country, but also export them. In Bangladesh, of course, it was completely dependent on exports. The current status of the country has also meant that 90% of its vaccination requirements are actually met by Gavi, and that's how dependent it is. So, number one, as it moves up the LDC ladder and it transitions, Gavi support is going to roll back from 2029. That's number one. And number two, again, according to the UN listing of countries, it's going to move towards a middle-income country by 2031, which again means the kind of waivers and the kind of protection it gets under these categories will no longer be there. And it needs to be self-sufficient, A, for its own self, and then B, if it wants to use this as an opportunity to be a vaccine exporter, and as vaccines are increasingly, the need for them to be seen as public goods has emerged. Bangladesh as a country can also play a role. So this project really fits into that vacuum, where the first phase is a fill and finish human vaccination focus, and the second phase is a complete life cycle approach. And that's because that requires more manpower, technical expertise, and by the second phase we will have that in place. This is being set up in a district called Gopalganj, where the land and so on acquisition has already happened, and some very exciting, I think, features which, as an MDB, it has the ability and the capacity to negotiate that with a client country. So to make sure that there are features such as greening and full electrification of the facility. There is in the STEM workforce, about 40% have to be women, and so on and so forth. So a lot of novel features as well in the designing of the project.
Thank you. You were talking about the technical aspects of bringing out vaccines, and that's a perfect segue to Guru, who is with the U.S. National Academy of Engineering. Tell us about your perspective on all of this.
So let me get to the operational aspects, a couple of them, guided by 2 tales from distant history that may not seem relevant on surface. And we will pull out a couple lessons pertaining to vaccine distribution and deployment. The first one relates to the Denmark of 1917. You have to imagine Agner Erlong, a red-bearded bachelor engineer who's working for the Copenhagen Telephone Exchange, and he's wrestling with this problem that would unexpectedly transform public health. Phone calls those days were taking up to 15 minutes to be connected because people were having casual conversations, and especially the demands during the peak hours were enormous. And the standard engineering solution is add more capacity, more lines, more switches, and so forth. So he came up with a bunch of queuing formulas that are utterly transformative. And they dramatically helped transform the telecommunication infrastructure over the years. But what made his insight utterly remarkable wasn't just its mathematical elegance, it was the timing. Just months before, months after rather, he published the queuing formulas, the 1918 flu pandemic happened. So suddenly, the work on telephone networks became crucial for public health. So the same phone lines, and we've all been through this just recently, the same phone lines had been clogged with casual conversations, became lifelines for quarantined families. Doctors were providing remote care, and communities were able to maintain connections. And they were physically separated, of course. So in the US back then, 1 in 8 people, this is 1920, had phone connections. And these remarkable networks enabled social distancing of the time. Phones rang with medical updates, weather reports, even lullabies for babies in isolation. Decades later, a couple decades later, in New England, Margaret Hutchinson, another engineer, confronted what seemed like an insurmountable task, which is to turn penicillin from a lab curiosity into a life-saving technology. Of course, Alexander Fleming accidentally discovered it. Now, how do you make it into medicine? And the numbers tell a staggering story. From 400 million units in the spring of 1942 to 650 billion units by fall 1945. These numbers mask the true engineering achievement. Hutchinson's genius wasn't simply in scaling the production, it was in creating manufacturing standards that were robust enough to ensure quality across the world. And we still use some of those techniques in food production and pharmaceutical production. So while scientists were focused on perfecting the penicillin strain, here the lonely unknown engineer is trying to drive a production process to guide vaccine delivery on time. So what do these have to do with modern challenges in vaccine deployment and delivery? First, let's look at the ultra cold chain requirements for, let's say, the mRNA vaccines that have been profound in enabling newer forms of quality of life, I guess, after COVID. They require, I think, anywhere between minus 20 to minus 90 degrees Celsius or something, depending on what technology it is, to ensure perfect preservation. The perfect solution, however, has the potential to create a systemic failure. You see, it's exactly like the early telephone networks during the airline time that worked flawlessly until everyone tried to use them at once. So in many parts of the world, we end up with a perfectly preserved solution that doesn't reach the ultimate beneficiary, in this case, patients. So we have a lot of issues to think about, like temperature stable technologies, and how do you think of a reliable infrastructure to get the people dosed. Second, we face a similar challenge, much like what Hutchinson faced in terms of at-scale production these days, while maintaining consistency across facilities. Even though we have cheaper technologies, cheaper platforms here in India, of course, other countries are more expensive here. So Hutchinson designed protocols that could bend without breaking. So how do you come up with resilient infrastructure? Now, this is something public health people are frustrated about. Even engineers are deeply frustrated about. So I think this is an important challenge for us to be thinking about. So we need vaccine systems that are engineered for resilience than for efficiency. That is the basic point here. And I'll just finish by noting the legendary Sir Ronald Ross, who won the Nobel Prize for his work on malaria, who said that it takes oftentimes a decade to understand a new idea. But we've all acknowledged that, we all know we don't have decades for such understanding. What do we do under these deeply constrained environments?
Thank you. And the mRNA was also recognized for a Nobel Prize in the work that was done. As an engineer, you pointed out in your book how to engineer a better world. If you could wave a wand, what is one thing you would do to prepare us for the next pandemic?
Focus on the utterly boring elements, and I think too often we get fascinated by the high-tech elements here, and of course we can get into the conversation, the cultural dimensions of how these technologies are taken up, respected, embedded. And too often we ignore that, and engineers are utterly guilty about that. So too often we get fascinated by the ultra-fast, ultra-cheap type of works. But how do you focus on the boring, mundane forms of systems? Thomas talked about sanitation, which still remains one of the greatest public health achievements. And I think we have much to focus on the vexier parts of public health than the sexier parts of public health.
Vexier rather than sexier. That's good. We're going to go to comments, questions from the audience in just a moment. Tom, we are sitting here one day removed from the 5th anniversary of the announcement of the WHO worldwide emergency, the highest level that they could issue for the COVID pandemic, COVID-19. As you look ahead where we are today, how prepared are we as a world? And what is the impact of the US withdrawing from WHO?
Great. Terrific question. So I think it really depends on the health threat. We've made enormous progress against viral hemorrhagic fevers. So when you think about the Ebola outbreak, some of you may remember in West Africa in 2013 to 2016, it took multiple years to get this under control, billions of dollars, many countries involved. With each outbreak of a virus of this type, we've gotten better at it. So more recently in Uganda or the Democratic Republic of Congo, you've seen these outbreaks contained far more quickly, more cheaply. Even in some countries that are war-torn or have limited infrastructure, we've gotten better at it. The world is getting safer against that set of viruses. Where we're not getting safer, in fact, I might argue we've headed in the opposite direction, is on respiratory pathogens. Novel respiratory pathogens really depend on our ability to convince one another to take the steps that we need to protect ourselves and our loved ones. And I fear we're in the midst, in the US, you may have heard, we're in the midst of an outbreak around avian influenza.
Bird flu is...
Bird flu. And my fear is if this were to advance or emerge into a pandemic, because it will be more contagious, because our current antivirals and vaccines aren't that great against this particular spread, it will be far harder to convince people to wear masks, to stay home, to wash their hands, and really take those measures. So this willingness to protect one another, even when the risks are more to them than to you, is something where we've gone backwards. What does this mean in terms of moving forward? We need both international, regional, and local response. We have to work together globally around surveillance. Can't be done by just one set of countries, can't be done by one region, and we need a global actor to help coordinate that. It's incredibly important that we have a competent global actor like the WHO to coordinate this surveillance function. Can't be done more locally. We heard some great examples around vaccine capacity. We need more regional capacity in the regions that weren't able to manufacture vaccines in a timely way against emerging threats. And then we need to do the hard work to rebuild this trust around getting people to take these very rudimentary, centuries-old measures to protect ourselves when what the threat is something we don't have a medicine for. It's a new virus that spreads easily person to person, and we need to do the hard work in communities at the national level to do that, and the US is first and foremost on that.
Okay. We have a whole separate panel that Tom and I are on with Cal Penn and others at 2 p.m. I hope you will join us in the front lawn for that conversation. Vanshica, before we open it up to questions, wanted to ask you that burst in funding that the multilateral development banks did from 5% to 15%, now back to 10%, how nimble are they if we need them once again to step up? What are the lessons we've learned from the past?
That's a great question. I think definitely because of the recent pandemic, but also in general, there's a huge momentum now within the multilateral banks to become more agile and more lean and more nimble. So even the internal kind of organizational structures and strategies, we see across the banks have evolved a lot to make sure that they can respond to crisis situation, crisis response and management, and also to focus more on emerging areas and to spend more on resilience and to prepare in advance as opposed to kind of retrospectively having to deal with the crisis. And maybe I can give you some examples there as well. So for instance, health system strengthening and resilience building, that's a huge focus, say, to ADB, for instance. Another huge area that the bank's been focusing on the past few years is the intersection of climate and health, which again, that takes so many forms and is a very, the number of unknowns that emerge from that intersection are multifold. So to take bold steps where the bank has said, okay, we'll make sure that under every health project, at least 15% goes to climate financing, making sure that in every project there's a certain component focus around resilience building. Those are very specific features that have been taken. Along with that, even at a organizational strategy level and a country strategy planning that happens every few years, we see that intention is being showcased, and there's more and more action there. I think another thing that's been done to make organizations more nimble is to have a larger pool of experts, of development partners that are already mobilized and can be tapped into. So that's something that's also happening along with that. And a third is greater financial commitment as well in terms of the buckets and the budget lines.
Let's get some questions from the audience. If you have one, they'll come around. Please go ahead. Right there, yeah, the front. Go ahead.
Thank you. I have two burning questions. I hope both can be answered. The first is, as a chef and a nutritionist, I'm curious about what your message would be to those that don't believe in vaccines. I will ask you the second question as well. So between the two scientists here, I can get an answer, which is about the individualized treatments for cancers, how technology is being harnessed, how AI is being used, and where do we stand there with that research?
All right, I'm going to go to Guru first for the second question. You've been thinking about how to customize, how to value medical systems, right? So talk about that in terms of the cancer, and then we'll come back to the first question. Thank you.
Trying to find my wife in this crowd here. She's an oncologist by background. However, let me focus on.
Let's have her wave. Is she here? We should have her. Yeah, there she is. So you folks should chat. Yeah.
Let me try the technology aspect of it. No matter what the approach is, even if you go back to the earliest stages of theories of capitalism pioneered by Adam Smith and what we now have in the forms of artificial intelligence with its own value system. What ultimately comes down to is, I think this is a problem that's utterly puzzling, how we go about valuing the technologies that are priceless. And especially in this case, we are talking about vaccines that have potential to have intergenerational impact, unseen impact, unfelt impact. And it relates to an interesting paradox that Adam Smith coined back then. This is the 1700s. He talked about the water diamond paradox. Everyone wants water, much like vaccines, but vaccines are also expensive to produce, much like the diamond. So between water and diamond, which is more desirable? This is an interesting conundrum that he posed that still continues to filter through modern economic debates. And I'll get to the artificial intelligence here. Let's get this fundamental sorted out here. How do we go about valuing a vaccine, whether it is for cancer or some neurodegenerative conditions or just utterly preventable conditions that take unnecessary lives unnecessarily? Comes down to the logic of putting dollars in the numerator over some health benefits. Quality-adjusted life years or disability-adjusted life years as the things go. And some of these are official metrics, countries like United Kingdom, even the WHO, and so forth. But there is no agreement on what value actually means and from whose perspective. And this is where the technologies such as AI come in, providing customized results depending on the perspectives of the user. So how do you think about it? So it is simultaneously enabling and confusing at once as we think through even how do we think about valuing vaccines for these utterly complex conditions that we're talking about that have significant impact on health and peace even. So I think it comes down, for example, a government might want an utterly cost-effective solution. a payer or the insurance company might want the least costly solution. And the patient, of course, wants the most effective solution. Right there, you have a three-dimensional angle on how to think about this. And this is where ultra-fast, ultra-layered technologies such as AI can provide multiple perspectives that can enrich a particular worldview on how to think about vaccines or prescription drugs or medical devices. But it all comes down to this debate between value and values. Again, going back to the cultural element of it. That's how far I'll take it.
Thank you. We have only a few minutes left, so we're going to do short questions and short answers. I'm going to come back to you for that first question.
Really important question. So I would separate the people that are reluctant about vaccines into two groups. There is a group that is convincible. And largely what it is, it's people who have questions about the science. I've heard mercury is in vaccines, or I've heard the mumps, measles, and rubella vaccine causes autism, and you can talk to them about the science. You need to listen to them, take them seriously about their concerns, be, again, transparent about both sides of the arguments. Or this group also may include people who are historically vulnerable or marginalized, like some immigrant groups or racial groups, and there's a bad history of how some of those groups have interacted with the medical profession.
Including experiments in the United States.
Including experiments in the US. And again, you want to take those concerns quite seriously and talk it through. Unfortunately, there's a second group where it's really more tribal. It's a matter of identity, and it may also include people that frankly make money off of vaccine hesitancy. And in that group, you can talk to them about the science. You can talk to them about there's no mercury in vaccines. You can talk to them about addressing these issues, and they will just simply shift to something else.
Can you explain how they make money on vaccine hesitancy? Sorry to interrupt.
So some of it is just selling books and materials, getting people to pay for memberships in organizations. Some of it is then selling homeopathic remedies, natural remedies, as a way of convincing people to use those instead of vaccinating. But it's an enormous industry. And there, it's very difficult because frankly, you can't convince somebody whose paycheck depends on them not being convinced. And you really have to pick your spots, and that's a challenge.
Thank you. Go ahead. Short questions, short answers, please. Go ahead.
Yeah, good afternoon. My two very short questions are there.
One question, please. We have a lot of hands
Okay.
up,
Regarding the accountability of the governments in sense of the emergence of the new diseases. You know, when the new, like COVID also, it emerged, but no sense of accountability is there, whether it was natural or it was a lab-grown diseases, right? In that sense, and one plus much short question, that the recent, the US government, the president-elect have declared that he is coming out of WHO in sense of funding.
Yeah,
so what? So
I already asked that question, so we're going to move on, and he's already president. Vanshica, do you want to tackle the first part? Yeah.
Maybe I'll go back with, maybe
Okay.
I'll go for the second
Sure,
one, if I remember it correctly, which was on the withdrawal of the US from WHO. So there I'd like to say that institutions such as Asian Development Bank or even the Asian Infrastructure Investment Bank probably have an even bigger and more important role to play now to be kind of the bastions of international cooperation and collaboration in times where the political landscape is challenging. And it's important to note that in both these institutions, for instance, ADB has 68 member countries, AIIB has 110, and while they both have an Asia-Pacific focus, but our, at least AIIB is also global in nature, it has 110 countries. That's a huge number, right? And each country has a different shareholding size, but they're all members, and the bank runs based on equity. So these become very important spaces to drive high-level agenda setting, to set the stage, to then have move from the more upstream to midstream, downstream work, and to make sure that the projects that the bank designs and clears reflects important priorities, even when a particular government, or even if the most, a major leading country leadership may not be conducive. So I think they have an even bigger role to play. And I must say that all of these institutions, the global South countries, have now a more greater focus and a bigger role. And most of the projects actually are in either South Asia, Southeast Asia, the Pacific, or Sub-Saharan Africa. So the banks are really servicing these countries the most. They are the key clients, and I think that they will play a key role more so going forward, and will that way are a bit will face less of the threat that probably a WHO or other UN institutions face, where the US is a formal member.
Thank you. Go ahead.
So a question for the scientists. Everything is a risk reward. And with the mRNA, the art got rushed out, and there probably wasn't a longitudinal study on its efficacies. Is there any kind of studies that tell you, because in our WhatsApp groups, there are all these people talking about long-term bad effects. And so where are we today with the latest on the mRNA axis and how effective they are proving to be in the long run?
Want to go first?
Sure. I can tell you the vaccines save tens of millions of lives globally. You can see we did a landmark study both on the global differences, the drivers of differences between countries, and then a separate study in the Lancet looking at the drivers of differences in US states. You can attribute the vast difference, and I should say the difference, there's an almost fourfold difference in how the worst US state performed than how the best US state performed. That difference is almost entirely their vaccination rates. That gives you a sense of what the benefit was. Now, this has been used at scale in terms of the long-term effects. We haven't really seen very much, but there are certainly side effects. You saw some around cardiovascular concerns for younger male populations in particular. There may be some that emerge. Every vaccine has benefits and risks. Given the benefits we saw in the pandemic, they're quite significant. I'm still feel pretty good about what that ratio was for COVID-19.
There was a comment earlier about the responsibility. Who is responsible when these pandemics come out if they find there's a cause, whatever the cause may be? What should we do as a world?
So it's important that I think from a practical matter, how the virus emerged, SARS-CoV-2, shouldn't be as important. The reality is we need both lab safety and we need to address the drivers of vaccines jumping from, or viruses jumping from animals to people. We should do both of these things. I think politically, there's an understandable desire to have a transparent investigation around attribution. I do think it's going to be important moving forward that we have clear understandings about how these investigations are going to happen. But it's a hard issue to have one country open itself to international investigators, and that's been the challenge of convincing China to do that.
Okay, we have a question there.
Thank you very much to the panel. The comment that I'd like to make is more about the upstream funding of empiric research. So, for example, where Oxford University were concerned, they were already doing some research in the mRNA space, and then, they then turned that technology to COVID. So I was just wondering, in terms of funding, because I think that's where it really starts, the actual core science, right? Which one can then scale up. I mean, I've worked in vaccines myself, but I think what is often lacking is empiric research, the funding, and government institutions supporting those internationally as well. So I'd be interested to hear your thoughts on that. Thank you.
Guru, how do you look at it from, you're at the National Society for Engineering, but also health, medicine, all of that. So talk about that, please.
I have nothing but agreement here, but I think it goes to the foundational point about the role of government in not just generating, also regenerating and reinforcing the foundations of science, especially that informs health and engineering in this case. So it also relates to the point that Tom was making earlier about decision makers often find themselves in deeply constrained environments. And oftentimes health ministries don't have that luxury or capabilities to make enormous investments in this, and it ties in with other decision or power players in the Ministry of Finance or Ministry of Commerce to guide those investments. But I think how government should coordinate their act together, especially to plan for future pandemics, is an open question. I know a lot of my colleagues are puzzled about this, let alone, I mean, our competencies are routinely being tested, whether we can even handle an experimental pandemic, even after COVID. And those are some open questions. And it's, again, it just supports the role of government in driving vaccine-related research and communication. A point was made about WhatsApp communication earlier. The world is so confused, and as an engineer, I try to think about this concept of impedance match. You know, the sound system here, the speakers have to be matched with the amplifiers. So much like how the message has to map to the mind. So it's the notion of this uncomfortable knowledge and how people just live with simple, easy, and often wrong explanations of something that have greater stickiness.
Folks, that's Guru Madhavan. Please give him a round of applause. Vanshika, you have 30 seconds. We're getting the hook from here. So your thoughts.
So just to finish off and add to that point that on research and R&D and funding and identification of great work that happens at a lot of academic institutions, I think international organizations and MDBs are doing a lot of work there. We make sure that we try and identify, map which are the institutions of excellence where research is happening, making sure that whenever where we have convenings, we have workshops, we bring the best of talent. I think, as was mentioned also, governments on day-to-day also have so many other priorities. So to make sure that whenever we are engaging, we bring to them a menu or a bouquet of options of what can be done with the work that's happening, the experts that are there in the field, and why there's a need. So kind of provide the canvas, even if they may not have the bandwidth. So that's definitely to add there, a lot of work that we do. And just to close, I think on this point, I think the MDBs are playing a major role. And I just to reiterate the point that even with the withdrawal of the US from WHO, I think institutions like ADB, AIB, and so on, which are majority members are low-income, middle-income countries from the global south, they will play a key role in ensuring that we have wax nations at large.
Thank you. Vanshika, Kant, everyone, give her a round of applause. Tom.
Great. Just very quickly, there's a natural complementarity between the US and India on global health. The innovations that occurred here locally around the smallpox eradication campaign helped inform a US-funded smallpox eradication campaign globally. What you saw around HIV with Indian generic manufacturing and process innovations, taking a set of medicines first developed in the US, has enabled us to save 25 or 26 million lives globally, those combinations. We have the same opportunity on vaccination, really, in general, where you have a innovative industry here in India, again, with well-trained around process innovations, well-trained on vaccine manufacturing, that can help working with US innovations and ideally some funding from that standpoint, help expand access regionally and globally so that we're better prepared for the next pandemic and sustain the gains that we've seen over the last 30 years.
Thank you for that very hopeful panel. Tom Bolky, everybody. And thank you all for joining us.